Good morning. My name is Adele Turner and I'm the advanced practitioner from Lincoln County Hospital for blood transfusion. And I'm here to talk to you this morning about sample labelling and getting it right first time, and to go into a little bit more detail about why we reject certain samples and how we can improve the patient pathway and getting you those all important results in rapid time. So we work for a pathology network, which is called Pathlinks, and Pathlinks is a single managed NHS clinical pathology service which operates across the whole of Lincolnshire. We operate from 5 laboratory sites over 2,000 square miles and serve 2 acute NHS trusts, 2 private hospitals, 2 community mental health trusts and over 200 GP practices. This service is delivered by over 400 staff, including phlebotomists, medical laboratory assistants, managers and medical staff. Cellular pathology is centralised on the Lincoln site. It receives approximately 65,000 requests per year, and it involves both histology and cytology examinations and aids in national screening programmes for breast, cervical and bowel. Histology is the study of tissues and organs through the examination of microscopic architecture of tissues and that relationship between the different types of cells and the tissue found within those organs. Cytology studies cellular structure, cell composition and the interaction of cells with other cells and the larger environment in which they exist. Microbiology operates out of 2 sites within Pathlinks, and those are Boston and Scunthorpe, and they receive approximately 671,000 requests per year. Microbiology includes bacteriology, serology, and molecular studies. So bacteriology is the examination of blood, which includes the sepsis pathway, tissue, sterile and non-sterile fluids, swabs, feces for bacteria, fungi, and parasites. We also look at antimicrobial susceptibility testing undertaken on significant isolates. And we aim to support outbreaks with cultures, molecular testing and typing. Serology and molecular examines samples for evidence of infection by bacteria, viruses, parasites and fungi, and detection of the presence of these organisms in samples by molecular methods, including PCR. Blood sciences, which is my core discipline, we provide 24 hours service at each site, which are Scunthorpe, Grimsby, Lincoln, Grantham and Boston. And we offer chemical pathology, blood transfusion, haematology, immunology and andrology. Each laboratory in the blood sciences discipline is identically equipped performing standard operating procedures to provide a uniform service across Lincolnshire, or with the exception of immunology, which is based at Scunthorpe, and andrology, which is based at Boston and Grimsby. We also do some specialist testing, which is specialist coagulation, haemophilia and thrombophilia testing, and those are done at Lincoln site. Sickle, hemoglobinopathy and thalassemia test is done at our Scunthorpe site. And all our BMS staff are required by law to be registered with the Health Professions Council. And the staff are currently in the process of being cross-trained across all those blood science disciplines. So we will cover chemical pathology, transfusion, haematology, with the exception of immunology and andrology, which are still specialist services. And we receive approximately 3.8 million requests per year. So our sample labelling requirements, we have mandatory sample labelling requirements, and those are particularly important in blood transfusion. So we have mandatory labelling requirements for the request forms and for the samples, and those are a little bit different. So for blood transfusion, the mandatory requirements for a request form are NHS number, surname, forename, date of birth, apparent sex, sex at birth, location, clinician, name and signature of the requester, clinical details and an indication for transfusion if requested. But those can be tied into the clinical details. For the samples, we need NHS number, surname, forename, date of birth, date and time of collection, the signature of the person collecting this sample. And that's particularly important because if we need to refer those samples off to our reference lab, which is NHSBT in Barnsley, they will not accept those samples if they do not have a signature of the person collecting the sample. And that leads to another significant delay. And any high risk status if that is relevant. For blood sciences and microbiology, the request form labelling is NHS number, surname, forename, date of birth, and a high risk status if that's relevant. And the samples must have a surname, forename, date of birth, and high risk status if possible. Cellular pathology should have 4 request forms: NHS number, surname, forename, date of birth, the location and clinician, date of collection, sample type and site, again because they are just a single site but receive samples from all the other 5 sites. Clinical details including relevant history and any therapies that the patient is on, and high risk status if it's relevant. The sample labelling requires an NHS number, surname, forename, date of birth, date of collection, site of the specimen, fixation status of the clinically prepared microscopic slides, and a high risk status if relevant. So best practice, samples must be labelled at the point of collection by the person who's collecting the sample. We can't take those samples off to the nurse's station, for instance, and label them up there. They must be done at the bedside. We must ensure that correct patient identification prior to sample identification, and that be by checking the wristband and asking the patient to give them the correct details. So further information, you can refer to our external standard guide 9, which is our expected standards of pathology request form and sample labelling, and that is found on the NLAG website. So what could go wrong? So it's a legal requirement that all healthcare workers ensure that all specimens are submitted to the laboratory in a safe manner. And you may not know that it is actually a legal requirement. So if those samples aren't labelled correctly, the patient or user information is incorrect. They can lead to labelling errors. It can lead to wrong containers being used, incomplete request forms, which will mean that we either need another request form or we need another sample and request form being formed. It can lead to incomplete sampling. There can be order of draw issues and delay in time of collection to receipt. So the consequences of the patient or user information being incorrect, and these consequences can be quite significant. So there's a risk of incorrect diagnosis or treatment. So if that patient information is accurate, then the results may be misattributed, and that could lead to inappropriate clinical decisions, including incorrect treatment of the patient. There can be IG breaches, and those can either be incorrect user or clinician details, and those may result in the results being sent to the wrong place, so the wrong location or the wrong clinician, and that poses a serious risk to patient confidentiality and data protection compliance. We could need repeat sampling and additional procedures being performed. So rejected or mislabeled samples often require recollection, and this can cause unnecessary discomfort, inconvenience and anxiety for the patient. And it can also have an impact or potential delay to the patient's treatment or discharge. It can disrupt staff workflows, so time is diverted from core duties, so processing all the samples, to leading to investigate issues and contact users for clarification. And that is time for us and the clinical staff. And it reduces overall efficiency and increases workload for both clinical and laboratory staff. It can lead to an insufficient use of resources, so wasted materials, time and effort where samples must be retaken or forms resubmitted. Inefficient use of resources will result in cost implications for the trust, and it impacts both user departments and laboratory services. So I'll discuss the impact on patient care and workflow. Accurate and complete labelling of samples is critical to ensure timely diagnosis and treatment and to improve the patient pathway. Labelling errors can lead to serious consequences for both patients and for staff. So key risks that we identify are delayed patient pathway, so missing priority labels. So if that's an urgent suspected cancer, if we don't receive those samples as urgent, that can lead to delays in processing, and that impacts on urgent treatment timelines. Unlabeled samples, so samples without any patient identifiers, are automatically rejected by the laboratory, and it requires relocation, causing distress and inconvenience to the patient. Increased staff workload. Our time is lost investigating those incidents, completing incident reports and communicating with the clinical teams. But that is also seen on the clinical side because we have to contact you and disturb you from your busy schedule. So some assumptions that have been made. So staff are unable to make assumptions on patient IDs, and that results in repeats being required. So we can't just assume that that patient on that request form is associated to the sample in the bag if it's inadequately labelled. And that can lead to a potential delay in getting repeat samples and unable to determine what the patient requires. Sometimes we're unable to phone the location to bring awareness to rejections if information is not available. And that's because we're all really busy and you just sometimes don't have time to answer the phone, but we're trying to get an urgent repeat sample. So best practice, always double check patient identifiers and priority labels before sending those samples, and that is to be done at the time of collection. Using electronic requesting where available over manual requesting is preferred, and that reduces your labelling errors. And always refer to the expected standards of pathology request and sample labelling if you are unsure, or give the lab a ring. So barcode errors, and you may think that this is not really very important, but believe you me, it is. So accurate and complete barcode labelling of the sample is critical to ensure a timely diagnosis. A skewed barcode, believe it or not, can slow down the testing of the samples due to our analysers not being able to read them, much the same as you go to Tesco's and can't read a barcode at those handheld scanners, which is awfully frustrating. So we can delay that patient pathway. Wonky or skewed barcodes can result in delayed processing. And what our analysers do is if they can't read the barcode, is those samples will sit on board the analyzer with all the other samples that they're processing until the rest of those samples have finished processing, and then it will put them in an errors rack. And that adds work pressures and delays processing time. And we know, especially with A&E, that we have an hour turnaround time target to achieve, which impacts on those 4-hour patient turnaround times that we see. So relabeling within the lab can increase the risk of potential errors and incur cost implications. So we can relabel using barcode printers, but again, that adds an additional risk of the lab staff putting the wrong barcode on that sample. And also you've got the cost implications of the printers and the labels that we use. So best practice, please ensure that the correct barcode is attached to appropriate tube, and those orders of samples are actually on the WebV electronic request form. So you can check WebV if you're unsure, and that will minimise delays to testing. Please ensure that the barcodes are put on straight down the tube and not wrapped around the tube or wonky. And I'll show you a few pictures to elaborate on this. Okay, so our blood transfusion racks require the sample barcode to be aligned with the barcode on the sample block. And if they're not visible in this sample block, then the analyzer simply won't read them. Our coagulation racks require the sample barcode to be facing outwards to ensure the barcodes can be read. And that allows the test to be requested via the laboratory computer and then automatically downloaded to the machine, so it knows what test to perform. So if you think you've got a barcode that's wrapped around in a kind of circular motion, our analyzers are never going to be able to read those. And chemistry racks require the samples to be aligned centrally and have the barcode clearly displayed through the gap in the rack to allow it to read. So Nice straight barcode. Everything should be fine. So our order of draw. To ensure accurate testing and patient safety, blood tubes must be collected in the correct order of draw, and any deviations of this can lead to erroneous results, sample rejection, delays in diagnosis and treatment. And why does it matter? So there is a risk of contamination from the preservatives and anticoagulants that are in the bottles, which can affect patient results. So we need to always follow the correct order of draw and refer to the Vacuette selection guide if you are unsure, and these are available on the ward. WebV forms print with a test order from top to bottom, and you can follow that for guidance. Or you can contact the laboratory for advice if the test isn't listed on the above document. The use of discard tubes is vital to ensure that the accurate tubes filled and reduce repeat bleeding. And I know that we use a discard tube in our A&E departments to try and avoid that. And that's especially important with those coagulation tests because they are the first line in the order of draw. So we can get barcode issues with a WebV form, but they do, as you can see on the left-hand column, give you an order of draw in there. So it will indicate that the light blue sample is first, then purple, and then yellow. So that should help you with that order of draw too. We do realise that some of these WebV forms sometimes are not printed correctly, and they're down to generally your barcode printers, and they just need a new ribbon if that's the case, if they're coming out a little bit faint or scanty. Incomplete sampling. So to ensure accurate testing and patient safety, blood tubes must be filled to the indicated mark. And this is where a discard tube will come in handy. So each tube is validated for a specific volume in that tube, and deviations in those volumes can lead to erroneous results, sample rejection, delays in diagnosis and treatment. So tubes for coag samples, for instance, contain a clotting agent, and if those are underfilled or overfilled, can actually compromise the test integrity, and they give test results that are actually true. So the laboratories are unable to process samples that fall outside our validated range volumes. So best practice is always fill to the designated line and double check before sending to the lab. And if sure, consult phlebotomy guidelines or the laboratory staff. We sometimes see delay from collection to receipt, and they can actually compromise testing integrity and those patient outcomes. So some of our tests require processing within hours to prevent clotting or cellular degradation, and delayed receipt may render that sample unstable. Any delays in centrifugation can impact on patient results, so we need those samples as soon as they're taken to be sent to us either via the pod system if those sample types will allow, or via the porters or junior staff. So an example of a delay in impact for delayed centrifugation is a reduction in glucose and an increase in potassium, and those are false elevations, particularly the potassiums. So histology specimens, they must be received promptly to allow proper fixation and processing, and large resections may require immediate opening and further fixation. So if they're received late in the day or after a weekend, then those tissue qualities may deteriorate, and that can affect diagnosis and accuracy. So best practice is to ensure prompt transport of all the samples to laboratory. For time-sensitive tests, prioritise those dispatches and inform the labs if delays are expected. Use designated transport schedules and avoid holding those samples overnight. So, incorrect sample containers. Certain diagnostic tests require specific containers to ensure the sample stability, accurate processing and results. And using the wrong container can lead to those samples being rejected and delays in that patient care. So examples of this are FIT tubes, so they're fecal immunochemical tests, and they must be submitted into the designated FIT collection device. And samples in universal containers unfortunately can't be processed. It must be in the correct device. Histology samples must be placed in formalin-filled containers. Any dry sample may compromise that tissue fixation and affect diagnosis and accuracy. So what you can do is always check the test requirements before collecting a sample and use only the approved containers provided by the laboratory. If unsure, contact the lab for guidance before collection and refer to our pathology user guides. So examples of our containers. So the charcoal swabs are for nose, ear and throat, FIT tubes, formalin pots and our sputum pots. So hopefully there aren't any questions. So blood transfusion, and this is my core discipline. So where I work multidisciplinary in the blood science department, but I am in blood transfusion, and blood transfusion samples and rejection rates are higher than any other area, and that's because of the guidance that we need to stick to from the British Society of Haematology. So we have a 2-sample rule and those timings in relation to transfusion. So in line with PSH guidelines, 2 confirmed blood groups are required prior to the release of group-specific cross-matched blood components. Now that doesn't mean that in an emergency we can't use blood group O because we don't want to delay those the urgent release of blood in those situations. A second sample with a request form is required due to the possibility of inadequate patient identification and labelling errors which lead to an unaccepted risk of wrong blood in tube. So that first sample, when we talk about it, can be historical already on our database, and those are available on WebV. So if you log on to WebV, you will be able to see whether you need to take 1 sample or 2. Or it can be independently taken on the same day as the second sample. So that second sample must be a separate venipuncture, and that should be less than 5 days prior to the surgery or transfusion. Ideally, we don't always live in an ideal world, they should be performed by a different staff member, and that's to reduce those wrong blood in tube errors. Ensuring 2 separate positive patient identifications have been carried out. A separate request form must be sent with the second sample. So you can't just send 2 samples in the same bag that were taken at different times with the same request form. It must be 2 separate forms and samples. So patients requiring red cells that do not comply with these guidelines of 1 sample on 2 separate occasions must be provided with group O only until that blood group check can be established. So where possible for the labelling, ask your patient to tell you their full name and date of birth and check the wristband, name, spelling, date of birth and NHS number. Unidentified patients will be given a unique identified when admitted through A&E. So it's really important to know that any misidentification can lead to fatal ABO incompatibility blood transfusions, and those we have to report to SHOT and to SABRE, which is through MHRA, our governing body. And it can lead to death of the patient or significant consequences for those patients, which we do not want. So sample collection for transfusion, we use 6 ml EDTA tubes, and all of those sample labels must be handwritten. We do not use any electronic forms for transfusion, and we don't use address graph labels. Labelling of the blood sample from the patient's ID wristband and not the request form or the case note, so it must be from the request band. And any misidentification, again, can lead to ABO incompatible blood transfusions, which we very much would like to avoid. So just to give you a little overview, between April 25 and June 25, Pathlink's transfusion departments received over 37,000 test requests across all the sites. Of those, more than 900 of those tests were rejected, which highlights the significant operational pressure and potential areas for process improvement. So for April 25 to June 25, we received over 142,000 test requests from a single hospital department across all those sites. And that was excluding all other wards and GP practices. And more than 19,000 of those requests were rejected. And again, that highlights significant operating pressures and potential areas for improvement. And this is just a visual to establish and show what type of sample types we do reject more. So the main rejection is those samples delays. So where the potassiums are falsely elevated because they've been delayed. We do have hemoglobin, so from your full blood count rejections, but our main ones are the U&E rejections and the coagulation rejections. So we do manual request form audits as well, and we need to publish those. So we reviewed a total of 999 request forms, but that represents a very small proportion of the total requests which are received in that actual period. And only 7% of those met the required standards. 31% of those had eligible clinicians' names, so we can't track down who the relevant clinician is, and 54% had either illegible or blank location fields. Again, that means that we don't know where we need to code those results over to. So the consequences of incomplete request forms: we can delay that patient treatment. So incomplete or incorrect forms may lead to sample rejection or form rejection. It means that there's additional paperwork for yourselves and for us. So we may have to complete disclaimer forms before processing, especially if those samples can't be repeated again for histology and cytology. And these delays can postpone diagnosis and treatment, potentially impacting on those patient outcomes. It can lead to misrouting of patient results. And if the clinician or location details are missing or incorrect, the results may actually be sent to the wrong recipient or not sent to anybody at all because we just don't know where to send them to. And that can lead to confidentiality breaches and delay in clinical decision making. It may lead to the need for repeat sampling. So rejected samples often require the patient to undergo another procedure, and that can cause discomfort, inconvenience, and anxiety for the patient. There is potential delay to patient treatments due to repeat sampling. It can disrupt our staff workflow, so clinical, laboratory, and admin staff must spend time investigating the issues. And additional time is spent contacting the clinician or department for clarification, or just to communicate that we need another sample. Time and materials are wasted when samples must be retaken or additional forms are completed. And that, as you can imagine, reduces overall efficiency and increases operational costs. So we have a zero tolerance for transfusion. And so you may have heard us ringing all the time asking for a repeat request form. And that's because all of these details aren't filled out correctly. Now we need this information to make sure that the blood transfusion is going to the right patient, but also that the transfusion itself is appropriate. We have a lot of specialist transfusion knowledge, as you can imagine, and we do have an appropriate use policy in ULTH, which basically is leading to a single unit transfusion rather than historically where it was seen that 2 units were just an adult standard dose. We're getting away from that and moving over to a more clinical pathway. So does one unit actually improve those patient conditions, and then we don't need to expose them to a second donor, because the units aren't all from the same donor, because there's 300 ml of red cells in there. So we want to reduce that donation risk, because if we expose the patients to more donors, that can lead to the formation of antibodies, which leads to a patient delay, because we have to do additional testing. So the less actually that we can give them to improve their clinical condition, actually the better. So how do we notify the user of results? So we can contact GP out of hours. So critical test results within the ranges may be phoned to the GP following morning if the local out of hours unit is closed. But critical ranges outside of range and all other critical tests will be telephoned immediately to the source. So you can imagine, if we don't actually know what source that is, then we can't telephone those urgent results, and that will delay inpatient treatment and can lead to potential death of those patients, especially if we were ringing a troponin result, for instance, and that troponin result is high, and that indicates that that patient has had an MI or, some degree of heart failure. So our examples of our results are sodiums of less than 120 or greater than 155, urates, non-obstetric, greater than 700, or any AKI stage 2 or above. And it is the responsibility of the GP out of hours to then follow up of any phoned results. These telephone limits are prescriptive, and the clinical significance and urgency of abnormal results depends on the individual circumstances of each patient sample. Again, why we really require clinical details, so that we can see, well, is this patient actually known? Are they on any form of dialysis? Are these results stable for them on their treatment pathway? So then we might not need to phone them. Whereas if it was a first presentation of those results, then we would, and we need those clinical details and the correct location to be able to promptly give those results in time. So for cellular pathology, any unexpected cancers will be emailed to a clinician with the trust cancer manager copied in, and that ensures the email will be acted upon, and that's even in the event of a clinician absence. Or any significant incidental finding may be telephoned to a clinician, and that depends on the urgency, where those urgent stickers come in, and a follow-up email sent to the cancer manager in copy. Microbiology, positive results of specific microorganisms require notification to the user via telephone in wards, etc. And a few examples to note are organisms in gram film or isolated from CSF, any positive blood culture, positive pneumococcal Legionella urinary antigen testing, TB, carbapenemase producing enterobacterials, new cases of any HIV, Hep B or Hep C, or organisms of a serious public health such as measles, typhoid and brucella. We do have certain turnaround times to hit. So histology and diagnostics cytology. So there's urgent or 2-week wait samples, and we need to process those within 10.3 days. And routine samples are 32.5. Blood sciences, you can also refer to the user guide for any sample timings, as there's a huge long list for each different sample type. But as a rule, our target times are as follows. So for urgent biochemistry from A&E departments, medical admissions, we all need to turn around those times within an hour. So you can imagine those barcodes, if they're on one key, that's going to delay that hour turnaround time, because that sample is just sat on that analyzer whizzing around, not knowing what to do with it. Any routine, non-urgent, inpatient biochemistry are within 4 hours. Routine, non-urgent and GP outpatient chemistry are the same day. Andrology reports 5 working days. And samples referred to specialist laboratories are normally 1 to 2 weeks, but for some where we need to send them off for specialist testing to London, Newcastle, Edinburgh, for instance, those can take several months for the results to come back. So we have a minimum target of 95% of tests to achieve their turnaround time, and in order for those internal KPIs to be met, that's all monitored through our Pathlinks Managers Board. Any add-on tests which aren't part of the original test subgroup actually don't have a turnaround time set, but if there are any urgent ones, then we need them to be phoned to the lab and we can get on with those straight away. So microbiology, all those turnaround times for specific tests are available within the user guide on the Trust intranet, but urgent samples should be preceded by a phone call to the laboratory to ensure that the lab is aware and we can ensure that the correct samples are sent and escalate it to a consultant microbiologist if that is required. I'm going to bust this here because we all know that there are a few. So any lost samples or binned before testing, we want to bust these myths. So common causes of lost samples. The most common cause are our air tube system failures. The hospital's pneumatic tube system may be down or it may be malfunctioning and we haven't noticed. And the samples sent through the system might get stuck, delayed or sent to the wrong pod station. And those delays can in fact compromise sample integrity and require retaking of those samples. Reception non-receipt. If the sample never arrives at the lab reception, we can't accept it or process it, and that could be led due to misrouting, misplacement or potential transport issues. Uncancelled test orders. So sometimes a tested order, but the procedure is abandoned. So that patient might refuse or it might be a clinical decision. And if the test order isn't cancelled, then it appears as a missing sample on our system. Samples without proper ID or packaging may be rejected or lost in transit. Or if those samples are unlabelled totally and the request form's unlabelled totally, we simply do not know who that patient those blood samples are from. So there may be miscommunication, incorrect handling or failure to follow protocol can result in samples being misplaced or missed or discarded, or they may get sent off to another site where they didn't actually need to be. So we're going to do a little Taylor Swift shake it off reference. So shaking of those samples can actually cause those samples to hemolyse. So we don't want to be shaking those samples, we want to be gentle with them. So our common causes of hemolysis, which we see, are collection technique. So using a needle that's too small, and this increases shear stress on the red cells that we're testing. Vigorous shaking of those samples, we really don't want to vigorously shake them. Gentle inversion is recommended instead to make sure that whatever is in the tube at the time is mixed with those samples. So sodium citrate for coagulation, for instance. Drawing sample from a drip arm, we can't use samples from a drip arm as it causes dilution or contamination. So if those samples are stored incorrectly, especially with temperature, so extreme heat or cold can damage the cells, or if the tube systems or rough handling have caused some mechanical stress, those can give red cell destruction results too. So wrong collection tube, using incorrect anticoagulants or additive can affect that cell integrity. Underfilling or overfilling can disrupt the blood to additive ratio. There are some patient-related factors, so we know that some patients are difficult to bleed, but multiple attempts or drawing from small veins can increase the hemolysis risk. Dehydration or poor circulation, they can make those blood collection more traumatic. So we want to make sure that those patients are hydrated before we take that draw. Okay, so we understand that sample rejection is really frustrating, and it may be perceived that we're being really pedantic or unnecessarily strict. But it is important to remember that rejecting samples is a critical part of ensuring that patient safety An incorrect or compromised sample can lead to inaccurate results, which could affect diagnosis and those treatment decisions. Please be assured that our staff do not take the decision to reject a sample lightly. We fully appreciate the impact that this has on the staff time across the hospital and not just within Pathlinks, but our priority must always be to get it right first time for those patients and to ensure that that patient is getting the correct result and the correct treatment. So we do kindly ask for your support and understanding with this, and our staff are just following established procedures, and that is to protect their patient safety. And I'm going to run through a couple of case studies. So I see it from microbiology. So a CSF that had been collected at 11:55 a.m. was only received in the laboratory with a routine evening transport at 18:10 p.m. No phone call had been received from the ward to inform a CSF sample had been taken. The sample integrity could have deteriorated. It made it increasingly difficult to report or unable to report anything at all. The ward was informed and reminded to phone the lab prior to sending any CSF samples. So CSF samples are on that list that the lab need to be aware that an urgent one is coming. Fortunately, in this case, the CSF was clear and no harm came to the patient at all. But analysis is time sensitive, so in terms of sample specimen integrity and potential impact on patient care, it is desirable to analyse those samples as soon as possible after collection. So what lessons did we learn from that? CSF samples should also always be phoned through to microbiology to make them aware that a sample is on the way. Increased risk patients been given unnecessary antivirals or antibiotics without a correct result to ensure that the patient is covered in the meantime. But that increases the patient risk of antimicrobial resistance, which we do not want. So cellular pathology. The department was made aware that a histology case had missed its MDT, which was on the 12th of May last year. And at the time of this incident, the department was sending routine cases to be reported elsewhere, and that was due to capacity constraints. The specimen was taken on the 29th of April, and that request form was not marked as an urgent 2-week wait. The sample was sent to be outsourced on the 11th of May, and the outsourced company was contacted on the 13th to then expedite that case due to being informed of a missing MDT, and the report was authorised the same day. So learning lessons from that. Please ensure that all the samples are marked appropriately. If that sample is urgent and it's on a 2-week wait pathway, please let us know. If this sample has been marked as a 2-week wait on the request form, it would have been reported in-house and not outsourced, and it wouldn't have missed the MDT or delayed that patient treatment. So please ensure that all the clinical details are available on the request form, and the department requires this information to ensure that relevant processes are followed. So blood sciences, 2 samples were received into the laboratory for the same patient. The results from one sample had a grossly abnormal U&E results, including an AKI of 3 and potassium of 7. And on checking the patient history, it showed that another sample had been collected 36 minutes prior to the abnormal sample, which had a normal U&E results. So that would automatically flag up that something was wrong. So as the patient ID was in doubt, we rejected both samples because we were unsure which sample was correct. And the sample had been checked for labelling errors, and both had been requested via order comms at a GP practice, and no lab error had been noted. The GP was contacted multiple times until a callback was received. And as you can appreciate, that takes up quite a lot of BMA's time. And the incident was discussed and the abnormal results were highlighted to the GP, and that could have been life-threatening for the individual. But because we didn't know which sample was which, we didn't actually know what the results were. And that led to the patient being admitted through A&E just to have a repeat sample done, because we didn't know whether those samples were gross. That sample was grossly abnormal. So learning lessons, always check the patient ID prior to sample taking, and check that Web3 request form is the right barcode for that patient to match the confirmed to confirm the patient ID prior to sending to the laboratory. So for blood transfusion, and these do tend to have a significant more patient impact, but to be honest, giving out the wrong patient can result in exactly the same things as giving someone an incorrect transfusion. It can lead to inappropriate management of the patient, or it can lead to urgent results not being actioned, or it can even lead to death in some cases. So an F2 medic takes a sample for the cross-match for his patient, labels it and sends to the lab for a 2-unit transfusion. The nurse collects the bloods and checks it at the bedside and administers to the patient. The doctor returns to the ward later to blood is being transfused to the wrong patient in the adjoining bed. So how did that happen? So the medic labelled the sample using the patient's medical notes. He wrote the request form, prescribed the blood and documented the need for transfusions in the wrong case notes. The patients luckily did not have a reaction and survived. And the patient's blood group was B pos and was luckily transfused with O. So consider what would have happened if that was the other way round. So if we would have transfused a B positive unit to an O positive patient, it can lead to a transfusion reaction and potentially death. So the distribution of ABO groups in the UK is about 44% O, 42% A, 10% B, and 4% AB, which was why O was chosen for this. In Lincoln, we only stock a couple of units of blood group B because there's only 10% of the population that actually have blood group B, and about 4% of the total population donate to. So there's not a lot of B around. So it was reported to SHOT, which is serious hazards of transfusion, as a wrong blood in tube and wrong blood transfused. So why is it important to get it right first time? Patient safety. Doing things correctly from the start helps prevent errors that could affect the patient's health, diagnosis, or treatment. Efficiency. Repeating tasks or correcting mistakes takes time and resources, both for the lab and for the clinical areas. So get it right first time helps staff work more efficiently and reduces those unnecessary delays. It means that we can get those patients seen in our A&Es and get them admitted to the wards more efficiently. So staff wellbeing, avoiding rework reduces stress and frustration for all staff, so clinically and in the lab, and helps maintain morale and focus. It improves trust confidence, so patients and colleagues are more likely to trust the care and decisions being made when things are done correctly and consistently, and that's why we do have such strict adherence policies. And it means that we give a high standard of care to those patients, and we're giving attention to detail to lead to better outcomes and experiences for those patients which we are treating. And we need to work together to improve patient care, and we understand that everybody is under significant pressures. The laboratory is under significant pressures too, as well as the wards, but we need to maintain that understanding between each other, that we're all in the same boat really, and that all we're trying to do is improve that patient pathway and to improve the standard of care for that patient and get that patient the right treatment in a speedy fashion. So we're all managing high workloads across the hospital, but we really appreciate all the hard work and commitment from all the staff areas. But to improve our current situation, we'd like to encourage more collaboration and understanding between the departments. Patient safety and care are our top priorities, and we believe that learning more about each other's role and processes, we can work together to be even better. So our lab is open to scheduled visits, and you can contact a lab at any time and get information on how to book a little tour around the lab. You can then have a hands-on view of what a lab is like, and vice versa. Our lab staff would love to go out to the ward and have a little, hour session just to appreciate the patients at the end of it, because we don't always actually see the patients at the end. So we would love to welcome any feedback or ideas for improvement that you may have. We're always open to engagement from the clinical areas. So please send your suggestions to members of the PathLinks Pathology Quality Management team, and that is Ben Francis or Emma McMillan, and their emails are below. And I would just really like to thank you for your time and support on this matter. Thank you.